Excellent. All right. So I want to talk about the initial approach to vertigo, when to take a hint. Just click. There we go. All right. So there's a few different physical exam moves I think that we've all probably heard about for these vertigo patients. But it took me a while to understand that each one is meant for kind of a specific scenario, a specific type of vertigo patient. So I want to focus mainly on the hint exam, but it's hard to talk about that without talking a little bit about the Dix-Hallpike, then interpreting the hint results and what kind of the evidence base is for using it. So the case to start with, 65-year-old lady, hypertension, diabetes, and she's had this specific kind of room spinning around her feeling for a couple hours now. And it's not really getting any better. She's vomited a few times. She does say it's worse with head movement, feels a little off balance while walking, but is still able to get around, and no other real complaints at all. So it's giving you this kind of picture. On exam, laying in bed, not looking great still saying like, oh man, I'm really spinning. And when you look at her eye movements, you do notice this like pretty persistent left horizontal nystagmus. Everything else looks great though. No neurodeficits at all. You do a very detailed cerebellar exam. No problems at all. This is a little closer look at what you're seeing on the eye exam. So what's in our differential so far for this person? Yeah, right. So, you know, she did say it's like worse with head movement. So there's that. The point is, right, we always try to figure out, okay, peripheral or central. And there's a whole laundry list of characteristics that are associated with peripheral causes, a whole bunch that are associated with central. For me, it's a little tough to just kind of memorize all that and then try and figure it out, especially when a lot of these patients seem to give kind of overlapping categories whenever you talk to them. So for me, it's a little easier to think of just kind of like the big three, what I've gathered from some readings, basically BPPV, vestibular neuritis, both like peripheral causes, kind of the most common peripheral causes of vertigo, or are we dealing with a posterior circulation stroke, the one thing that we kind of never want to miss if we can help it. So of these three, if you had to pick one, what would you pick? Yeah, for this patient. So yeah, I made it a little vague because, you know, yes, she does have the movement stuff that's exacerbating it, which is a little peripheral, but it's also been like pretty constant, which is a little more of a central thing. So if you're leaning a little bit more towards BPV, who here would Dix-Hallpike this patient? If I told you it is technically the gold standard for diagnosis of posterior canal BPPV specifically, and in theory, should be about 100% specific for it. Let's say no, but she's still like dizzy. Yeah. So I think yeah. So based off what I've been researching about this isn't really a good candidate for the Dix-Hallpike exam. You know, I sort of thought that you could just do it on every vertigo patient because if it's positive, then great, you can say it's BPPV. But that's not really the case. All vertigo types can get worse with head position. So there's really like a specific scenario where this is most helpful if you're going to do it. One, you have to have like a very suspicious story, right? Kind of intermittent, specifically worse with head movements. And the next thing to look for is that there's no nystagmus on your like extraocular exam. You can get nystagmus when you try the Dix-Hallpike, but they shouldn't really have any obvious stuff like that on their just initial exam. And again, they shouldn't be like persistently vertiginous, like in front of you in the ED, unless they're moving their head around and, you know, then it's going away. So in this specific case, it's really helpful to kind of slam dunk your BPPV diagnosis. But for this patient, fits into a little bit of a different category, what is called the acute vestibular syndrome, right? Is specifically defined as persistent dizziness and vertigo and nystagmus with the extraocular movements. Those are kind of the main two things. And then sometimes they can have postural instability, nausea, and vomiting. So when they have this AVS picture, the main question to answer is, okay, is this vestibular neuritis, which can cause a sort of persistent syndrome and is kind of harmless, or am I dealing with a central brain problem? And just a quick reminder, the vestibular neuritis, sometimes I have a hard time picturing it. Basically just targeted inflammation of that vestibular nerve. Can't get any more input from your semicircular canals. So when you can't really get spatial input from one side, but you do from the other, that sort of imbalance gives you the vertigo symptoms, basically. So this is where the HINTS exam is, at least in theory, supposed to come into play. Head impulse, nystagmus, and test of skew. It's specifically for these patients with acute vestibular syndrome. Again, in order to answer that question, vestibular neuritis, or like some peripheral reason for this continuing thing, or is it a brain problem that needs to get worked up with like an MRI or a stroke workup? So for the head impulse part specifically, this is what you're testing, the vestibular ocular reflex. All the little details aren't super important, right? It's basically your ability to turn your head and keep your eyes fixed on something in front of you. So what you're doing is basically taking the patient's face, having them focus on your nose or something else central right in front of them, and then kind of just jerking their head either to the left or randomly to the right and kind of back and forth and seeing what you're looking for. And you're specifically testing the peripheral part of this pathway with the vestibular nerve. So if there's a problem there peripherally, what you'll get is, let's say the head goes to the left, the eyes will continue going to the left with the patient's head and then sort of jerk back to the midline at what they're trying to focus on. So I'll show you a video of it. Let's see if it's, okay, that opened somewhere. Oh, there we go. Oh, Safari.
Okay, this.
So it's mostly when he goes to the left. See that little jerk back? It's most obvious at the very last example, I think.
There you go.
Yeah, one more. See, the right is all good. Boom. Can everyone see that? All right. Thank you. Thank you. And I think the one thing that's a little confusing was this is, so that's the abnormal result that you saw. And again, remember that means there's a problem with the peripheral area. So that's considered a benign result. For the nystagmus, you're basically doing your normal extraocular exam and looking for what's considered either dangerous or benign patterns. Right? I think we've all learned at some point that pure vertical nystagmus is more concerning, but also like purely rotatory or multi-directional is probably the one that's a little easier to miss. If they're looking to the right and then their eyes are beating right, and then they look left and now the nystagmus is beating to the left, that's considered more dangerous. Whereas benign is kind of what the picture that I showed you. It's always beating in one direction and more in a horizontal plane. And then last is the test of skew. You're basically kind of the same thing, asking the patient to focus on something right in front of them, like your nose. They're keeping both eyes open. You cover one and then just quickly move your hand away and move it to the other eye. And you're kind of trying to see what their eye's response is. Normally, you should be able to just have normal straight eyes. I'll show another, let's see, I'll just drag it over there. Yeah. So I think it's most obvious in this guy's right eye. You see it just kind of dangles down to the side and then drifts back. Can you see it? Yeah, again, a little weird. Right, let's make sure that doesn't. Okay. Sweet. So again, right, that's, I think a little bit of confusion comes in with the head impulse. You want to see an abnormal result to be reassured that it's something peripheral. Test of skew, if it's abnormal, right? It kind of makes sense. Your eyes should be drifting all over the place. So why use this? There was this kind of famous study, hints to diagnose stroke in acute vestibular syndrome. Prospective study took high risk acute vestibular syndrome patients, right? So again, they had nystagmus on their first exam, this persistent vertigo, and at least one stroke risk factor. Every patient got a hint followed by an MRI, and then admission for observation and serial neuro exams. And they were said to have a stroke as a cause for their symptoms if they had confirmation on that very first MRI. And their diagnosis was like peripheral AVS if there were no findings on the MRI, no neuroscience on serial exams, and the overall thing just followed what they said was a characteristic course. And they defined a benign HINTS exam as you needed to have all three of these things. So you needed the abnormal head impulse result, direction fixed nystagmus, the normal kind of one direction horizontal pattern, and the absence of skew. Whereas it was dangerous if you were dangerous in only one of the categories. So you had a normal head impulse, multi-directional or vertical nystagmus, or the skew deviation. And when they used that criteria, their answer was that the dangerous HINTS exam was 100% sensitive for detecting an ischemic stroke versus the initial MRI with relatively similar specificities. Basically what happened, a few of the dangerous HINTS patients had a negative first MRI, and then once they were admitted, either had like evolving neuro findings or they had a repeat MRI at 48 or 72 hours that had a positive finding on it. Which is pretty good. But it kind of makes sense when you read that the exam was performed by neuro-ophthalmologists in this study.
What was the prevalence of the disease?
Prevalence of the disease, I don't know the exact number, but it was done in like high-risk patients specifically.
Selection bias.
Yeah, probably. And they weren't blinded to the initial history and physical. So the idea is like, if you're reading about a patient with 20 vascular risk factors, and then maybe they had a little neuro finding on their exam that you read about, you might be a little more inclined to say like, oh, I think I do see a very, very subtle skew deviation here in this patient, which would kind of inflate the sensitivity of your test overall. And there are some studies that showed when EM physicians try to do this, the numbers aren't nearly as favorable.
You know, good attention to detail.
Yeah, things can change.
The MRI results.
True. So, yeah. But I think just the main things I wanted to get across at the end of this is like anything else, it's all about matching the correct test to the correct patient population. So, right, a BPPV story and no nystagmus on their exam and not acutely vertiginous in front of you, that's when you can try the Dix-Hall bike to like confirm the BPPV. Whereas if they have this acute vestibular syndrome, that's when you do the HINTS to kind of reassure, okay, this is vestibular neuritis or a stroke. It doesn't really make sense to do both exams on the same patient. I think I would have done that a few weeks ago, and I did. And it always was very confusing, and now it makes sense why a little bit. If the patient has central vertigo and is in front of you feeling dizzy and has nystagmus, and like I said, tipping them backwards, no matter what is going on, can make it worse. So if things get a little worse and you say, oh, positive Dix-Hall bike, that's peripheral, you've kind of falsely reassured yourself. Similarly, if you have kind of a slam dunk BPPV story, because it's paroxysmal, if you do the head impulse test when nothing is wrong with their inner ear system, you'll get a normal result, which again is considered dangerous. So you've kind of just, and I've done that. I've done like Dix-Hall bike and then I'll hint them and I'll realize like that didn't make any sense. I just won't present about it, I guess. And again, like with anything, we have to include the clinical context, right? If there's any obvious neuro findings on exam, this all goes out the window. And probably most of it is going to have to do with your confidence of actually doing and interpreting the exam. So I feel like for us juniors, it's probably worth practicing and maybe seeing what happens to these patients you're suspicious about, so you can maybe use it one day. That's all I got for now. Any questions?
I think that was a very, very good lecture. Again, it all starts with the history. And one of the things that also may point you to peripheral causes is if they have tinnitus, ear fullness, and decreased hearing. One of the entities you'll see in someone like this who's 65 years old, that you did mention, because you were talking about, this particular entity, but that's Meniere's disease. And you'll see that, but that's usually recurrent, and it'll have those 4 components, which is the vertigo, the decreased hearing, the tinnitus, and the ear fullness. Although those findings may not be there all at once, and it can be tricky. But you always want to check for that in this age, because they can eventually become deaf. You always want to check for hearing. The other thing is, usually if there is a central cause of the vertigo, you'll probably find this, as you alluded to, other neural findings. You might find cerebellar findings, or you might find findings that suggest a problem with the vertebro-basilar artery system and the brainstem that it supplies.
Yep.
Brian, could you just clarify what a positive dix sulfide is?
Yeah, so basically they go from having no symptoms to you have to have, so when they're laid back in the proper orientation and everything, they get the acute worsening of their symptoms. And then they get this very specific, like, rotatory nystagmus toward the downward ear. So, and that can be a little confusing because I said rotatory is bad, but that's if you're having the rotatory, like when you're just normally moving your eyes around. But during the dix sulfide, it's very, I wanted to include a video, I just didn't really have time, but you have to have the worsening of symptoms and this nystagmus that happens towards the downward side.
I think that's just important because when they quote things like the specificity of 100%,
Yeah.
both of those things. It's not just you jerk their head to the side and they feel horrible.
Yeah.
I think sometimes we just kind of
Yeah.
And I think this is really important to know this stuff, mostly because we're communicating with neurology, and they're going to throw out like, oh, this person has a exam, or a reassuring exam. And I think the thing to know is what you said is that the studies were limited, and how come they didn't reproduce that well in terms of, especially in our situation, we have a junior neurology resident and to say that that's reassuring and should discharge your patient, you really have to take into consideration the patient's perspective and some of the other components. So that was a very important point.
Dr. Willis was just saying it's very important to, the main function of knowing all this is to be able to effectively communicate with neurology, knowing that if some junior neuro resident says that they have a reassuring HINTS exam, knowing that these studies haven't been super validated. It's still useful. Correct.